profoundly money in the healthcare system drives the behavior of the folks who are providing care, whether it's the doctors or nurses or administrators, because I think people are used to thinking about that in other industries, but not so much in healthcare. So I'll give you some examples and I think it'll make it pretty clear. It may make you a little lightheaded and so forth, but it's, bear with me. Let me just take 1 second, though, to tell you a little bit about our system so you'll have a sense of the context of the comments I'm making. So the Princeton healthcare system has net revenue of about $400 million a year. We used to be based in Princeton, and some of you may know we moved to a 171-acre campus in Plainsboro. Our enterprise has an acute care hospital. We have a home care company. We provide, we have an inpatient psychiatric facility. We have outpatient programs of behavioral health and radiology and ambulatory surgery. And we have a couple of joint ventures. One of them is in fitness and wellness. We have some in clinical lab services. Actually, some of our radiology services are provided through joint ventures off-site. And we've been around since 1919. One of the neat things that we've been involved with is we built a new hospital about 2 years ago. And on the campus, we're working with for-profit groups. We're not-for-profit. We've been working with for-profit groups to build an assisted living facility, a skilled nursing facility, assisted living, age-restricted, independent living, a fitness and wellness center, adult daycare, child care, and a medical office building, and a power plant. And I'll come back to that in a minute because hopefully you'll see why those facilities and those services become more and more important to us in the future as the way we're reimbursed changes. So keep that in mind. And think about this as a driver. So the healthcare business in the United States is about $2.8 trillion. Now, some people think it's huge, some don't. To me, the numbers are so gigantic that I don't know how to put it in any context other than it's the size of the economy of France. So when people talk about changes in healthcare, they're talking about making changes in something really, really huge. One of the issues, though, is in that whether that $2.8 trillion is too much or not enough. One thing that seems to be pretty clear is of that amount of money, there are estimates of about $750 billion of that being wasted. So no matter how you think about these things in terms of values or how you think about it in terms of the impact on the economy, no one can be comfortable with the idea that we would be wasting $750 billion a year on unnecessary care and some other problems that I'll describe for you. And then to make the situation even worse, besides the waste, is there are estimates that are pretty commonly accepted that as many as 100,000 people die in hospitals each year from avoidable problems. Give you an idea for how huge that is. It's the equivalent of a 747 filled with people crashing every day. Now, you know when you watch the news, if something horrific like a crash like that occurs, all the airplanes get grounded and everybody starts trying to figure out what's going on. And I'm telling you that that's the number of people who are dying in hospitals and health-related facilities every year. So you put those three facts together, and you've got a problem that absolutely has to be solved. Then lay on it just one last thing. General Motors spends more on healthcare per car than they do for steel. And we spend more on healthcare than other countries that have a similar standard of living to ours. And we have to compete with them when we sell our products. So every time we have to sell something on the international market, we have a disadvantage because we're spending a lot more money on healthcare than they are, and it shows up in the product, and that keeps us from selling, and that keeps us from creating jobs. So it all starts to come back into a circle that just requires us to deal with the problem. The odd thing about it is we've been talking about dealing with this problem, well, certainly all of my professional life. So everyone's been saying, going back 30, 40 years, too much of our gross national product goes to healthcare, and there's all this waste and inefficiency and all these bad things. And in that time, it's only gotten worse. So the question is, why should we expect the system to respond to these economic pressures and these other pressures differently now than they should have or could have 20 or 30 years ago? And I think the answer is because we've run out of money. There's no more money in the system to squeeze out. And so think about that, and let me describe how we make decisions in the hospital, and think about that comment I made about there's no more money to squeeze out. So when I go to the hospital in the morning, the first thing I do is I look at what we call a flash report, sort of a dashboard on how we're doing financially and operationally around the enterprise. And it'll give me the occupancy rate, so I'll know how many patients there are in the beds. It'll tell me how many surgeries are scheduled, how many people are utilizing psychiatric services, ambulatory surgery, lab services. For me, a good day is when everything is full. A good day is when everything is full with people who have insurance. Now, I don't want you to think ill of me, so I'm going to catch up with this, but that economically is a good day for us. People with insurance, hospital beds full, operating rooms full, and all of the services that we provide that have the highest margins, that have the greatest profitability, are the ones that are the busiest. So another way of saying that is I go into work every morning trying to figure out how to take advantage of, to create as big a demand for our services as possible. Now, we don't do bad things like create disease or hurt people, but we're trying to figure out how to get as many people with problems that we can take care of at our place and people who can pay the highest amount of money. So think about what that means, and then think in terms of there being about 5,000 hospitals in the country that are like us. And every morning, the executives and others are showing up, trying to figure out how to provide as much care as they possibly can. And it's not a big question when you wonder, so how come the cost of care keeps going up? Because that's all we try to do, is figure out how to make the cost of care go up. The last point, and then I'll try to tie some of these things together, but the last set of facts is the average hospital in the United States has a profit margin, have profitability, or we're not-for-profit, so we call it excess revenue, but it's profit for a lot of purposes, of 2.2%, which is really a very low margin compared to a lot of other businesses. Now, keep in mind, $2.8 trillion. So we've got this 2.2% margin. And then there's been a lot of homework done to try to calculate what hospitals' margins are likely to be 10 years from now. So you look at how we get paid, you look at how costs are increasing for drugs and other supplies, you look at how care will be delivered in different models, how salaries will increase, and other costs associated with care. Those predictions say that we'll go from a profit margin of, let's just say, 2% to minus 15%. If we don't do anything differently than we do now. So it goes from positive 2% to minus 15%. When we talk to financial advisors, they say, you know, you really need to have a bottom line, you really need to have profit of about 4%. That way you'll have enough money left over to keep up with increases in salary, and you can replace equipment and facilities and introduce new ways of delivering care. So you need 4%. So add the 4% to the 15%, and now we're 19% below where we ought to be. And then the Affordable Care Act Obamacare, has built into it a reduction in Medicare reimbursement. And Medicare pays for about half of the people in the average hospital in the country, people over 65. And that's going to be another percent reduction, maybe a little bit more. So I'm up to 19%. Now we're 20% below where we would need to be if we don't do anything. So in effect, all the hospitals have to close. So that ain't happening. And so the question is, given the national imperatives, given the business problem that I just described to you, what are we going to do about changing the system to deal with these impossible problems? And the answers are coming from changes in how we get paid. So today, I don't think oversimplify it, most of the care that most of us provide, doctors and hospitals, is fee for service. So we do surgery, the doctor gets money, hospital gets money. We do a lab test, the hospital gets money. The more of them we do, the more money we make. And that's contributing to, a lot of people think, to the waste and some of the other problems that I talked about. So as long as you keep paying us to do widgets, we're going to keep doing widgets. So finally, there's the idea that instead of paying us that way, the insurance companies and Medicare as a government payer, Medicaid as a government payer, they'll pay us on a value-based method. So they'll consider the results as well as the cost. And they'll also create systems where the hospital and the doctors get to keep some of the money that they save and share it with the insurance company. So it's pretty straightforward. Instead of the insurance company giving us a 5% increase, the way they might have under fee-for-service, they'll say, we're not going to give you any increase next year, but we'll let you keep a third of all the money you save. Bless you.
Thank you.
Get it? So we get to, if we can reduce the amount of care that we provide, we can keep the money we would have gotten paid by them. And there are different formulas for it, but to make it simple, we would keep 33 cents, the doctors would keep 33 cents, and the insurance company would get its 33 cents. And the payers argue that that's going to work because there's just so much waste, right? $750 billion, that just stop wasting money and you'll get to save it. Because the way they view, the way it works now is they figure we're not willing to save it if we don't get to keep it. And it's true. Nobody wakes up in the morning trying to figure out how to provide less care. Hopefully they're not trying to think about how to provide more care than is necessary. So, and then another way that we are now beginning to be paid is they'll just give us, the insurance company, ultimately Medicare, will just give us a lump sum. And they'll say, here's X number of dollars to take care of Mrs. Smith this year. So now we wake up every morning, instead of feeling great because every single inch of our building is being utilized, you look at that same dashboard and you go, oh my God, every bed's full. I'm losing a fortune. You know, the ORs are full. I'm losing a fortune because all of those things are so expensive. A good day, in theory, is when the hospital and the OR is empty because I got paid to keep you healthy. I got paid to keep the most expensive resources in the system, to not use the most expensive resources in the system. So this was very timely. I'll give you a great example off of this brochure that I got this morning from a company I never heard of called Hopkins Medical Products. And they're promising to teach us how to keep people with congestive heart failure out of the hospital. talk about that in a second, but today, we'll wait, sort of, until someone who has congestive heart failure has a serious problem, and then they come into the hospital, and then we spend $10,000 a day for 5 days, plus more, to help them. If we're paid regardless of the care that's being delivered, all of a sudden, we've got all these smart people that are hanging around the hospital trying to figure out how to keep Mrs. Smith healthy at home and not allow that health condition that she has, her congestive heart failure, to become so bad that she has to go to the hospital. So it really changes everybody's incentive. What's making it complicated today is the inside cover of the brochure. It says, if you take advantage of everything we have to offer you, there will be 54% fewer in-hospital days, 16% fewer emergency room visits. So this is great, but here's the dilemma that we have. I'm paid today, every day, for hospital days and ER visits. And someday, I'm going to be paid the way I was describing it to you. So we sort of have a foot on the boat and a foot on the dock. You implement a system today that results in this reduction in inpatient use and emergency department use, and we start to lose millions of dollars a year. If we don't do it, it's sort of criminal, right? I mean, if you really know that you have a solution that's going to help people and you don't use it for financial reasons, it's unacceptable. It's simply immoral, and we wouldn't do it. But all the hospitals and doctors and other caregivers are stuck in between right now, where you've got these really modest margins. You've got a payer system that's morphing from that fee-for-service, do as much as you can to make money system, to a system based on prevention. It doesn't happen overnight. It happens over, could be decades, but it's certainly going to be at least from beginning to end 10 years. How do you manage through that transition? You know, I've actually gone to meetings at the hospital where a group of physicians that we employ were meeting and feeling really good about having introduced a case management system, sort of a patient management process, to reduce their patients' use of the emergency department. And they felt good as clinicians, and they felt good because they got to keep some of the money that they saved by not sending to the emergency department. At the end of the day, I go to a meeting in the emergency department where they're talking about how they've lost 10% in volume, and now they're losing money as a department. This is the same building. This is the same organization happening at the same time, so you can't even figure out the good news from the bad news. And you just hang in there and you just do the right thing, and you hope that the transition occurs as quickly as possible, making sure that everyone's doing what they need to do ethically. But it's very difficult. New Jersey used to have 147 hospitals. There are 72 now. There are estimates that as many as half of the 72 may well close within the next 10 years because of things like this. This is just one disease, but these folks, fortunately, are saying that they have a solution for reducing hospital days by more than half. So if you've got, oh geez, I don't know how many hospital beds there are in the state. 3 times 7, it's probably like 22,000-ish beds. You close half of them, you're going to end up closing more than half of the hospitals. And as it should be. If the care is not necessary, that's just going to be fine. How do you operate between now and then? And my preference is it's somebody else's hospital that closes, but we'll get through that as well. One of the other things that you'll see around the country, and particularly in New Jersey now, as a solution to the problems I'm describing, is the formation of these huge hospital systems. So it used to be 72 independent hospitals, each doing their own thing. Today, 80% of the hospitals in the state are part of multi-hospital systems. and I define multi-hospital as 3 or more hospitals working together. You've got, for example, Barnabas and maybe Robert Wood Johnson merging, that's 11 hospitals. Hackensack and Meridian hospitals, that's probably 10 hospitals. And then other examples, to the point where, except for about 20%, they're all in larger systems. And the reason they're coming together is, there are a couple. Primarily to create the scale that everyone believes, most believe, is necessary to reduce the operating costs. Because there is no scenario in the future where we don't get paid less for the care we're delivering. And therefore, the pressure to reduce operating costs just doesn't end. So, like the airlines, like banking, and other industries, the belief is if we can consolidate, we'll be able to figure out how to reduce more of our costs. Yes, sorry.
You make it seem like the hospitals are like on their own during this transition. Like, is the government doing anything to help through the transition?
Yeah, that's a great question. It's probably because that's how I feel, but it's not true. You know? But so that's a great question. They're not on their own. The government helps in maybe 2 important ways. One is, to answer that, I need to take a step back. So I talked about how scale might help us. So instead of 11 hospitals having their own human resource department, maybe there would be 1 human resource department that would be with less staff, as an example of that scale. Or when you buy cotton balls, you can buy so many of them that you get each one for less. So purchasing could help us. So that's a scale idea. The other big deal idea in how to be successful under that new payment system is to put in place a care management system so that we could take on responsibility for people from the time, from their home through the time they see the doctor, through the hospital, through home care or rehab or whatever other health needs they might have, including encouraging people to live more healthful lifestyles, participate in fitness and wellness programs, to stop smoking, to do manage weight differently, and other things that you're familiar with. So now we're incented to not just make sure those levels of care are available, but to make sure that we've put a system in place to enable people to move through the system as quickly and as cost effectively as possible, making sure that they get the right care at the right time. Well, we don't know how to do that because we don't do it. You know, we worry about things that happen in the hospital, and then the nursing home worries about things in the nursing home and the home care company. You get the idea. What we need to build is a system of people and data that'll enable us to move people through that system in a much more effective way. The key for that, and now I get to your point, is IT. You know, we do not have the information systems in place to collect the information, to process it, to understand it, and act on it. And it's a huge investment. For an organization our size, depending on how we would solve the problem, it would cost somewhere between maybe $35 million and $80 million. Trust me, that is as big a number as it sounds. That would be a very heavy lift for an organization our size. And it's a similar burden for all the hospitals in the country, because they'll have the same responsibilities, and they're working off of the same immature IT systems. The punchline is the government has created financial incentives to make it easier for hospitals and doctors to invest in the IT necessary to do what I was just describing. So that's probably the biggest one. The other is they've created pilot programs, and they've given us enough time to stop whining and put in place solutions, but they're giving us the chance to test the solutions without having to bet the ranch. You know, so lots of hospitals are piloting lots of solutions. Most of them aren't working, some of them are, but it's great to be able to get the support from the federal government to experiment without taking unreasonable risks. So they sort of protect us in that, they give us money, and they give us time, because we don't have the solutions all in place. And if the reimbursement, on the one hand, I complain that we have two systems or multiple payment systems in place at the same time. The other problem is, if it all changed overnight, we would be in trouble too, because again, we don't have systems that we can trust to manage things well. So the government does help, I think, in those two ways.
Yeah, I wanted to ask you, because the consolidation, we actually talked about this a little bit consolidation of healthcare, so 72 to 36 perhaps. Wouldn't that reduce competition and possibly just raise prices anyway?
Yeah, a couple of things. The argument is certainly being made in certain markets by the payers. You know, and the payers like the insurance company, Aetna, Horizon, Blue Cross, Cigna type folks, and Medicare and Medicaid. They argue what you're saying, when there's not enough competition. The only reason you guys are coming together is so you have greater leverage in contracting, and it's only going to result in an increase, overall increase in cost. So it's an argument about monopolies. And I do believe, from what I've read and heard in other markets, where that condition has occurred. You know, you can go to a market where there are millions of people, I don't want to make up the number, but a large market, and there are two providers. There's no doubt in my mind that they came together that way, so that when the insurance company says, we're going to increase your reimbursement by 3%, they go, no. Now, in New Jersey, when the payer goes, we're going to give you 3%, you go, oh, thank you. You know, there's no balance yet. So when we move in New Jersey from 72 independent hospitals to a half a dozen, maybe, systems, which represent those remaining hospitals, I think the courts and who are involved in that will determine that there's sufficient competition to avoid the problem you're talking about. One of the things for me that's interesting in the question is, when I worked in the Philadelphia area, there were two commercial payers, Blue Cross and someone else. I guess it was Aetna, Blue Cross and Aetna. Maybe it was Blue Cross and Aetna. Doesn't matter. They represented 80% of the market. So the opposite of what, the same problem, but the other victim, you know, where you're sitting there having a conversation where, as a hospital, you can't say no, because you can't turn away maybe half of your patients because they don't have the insurance, the one insurance that you've been able to negotiate. From a regulatory standpoint, insurers are considered, they're not considered providers, they're considered customers. So you can't have that problem with a customer, but it's not true. It doesn't work in my mind that way, but that's how it is. But yeah, it can absolutely create a situation where it's non-competitive. Far from it yet. Yes?
So in terms of like what you were talking about earlier about how you're gonna get people to, because you always want like full beds and stuff like that.
Right.
Wouldn't the direct solution be like just ensuring quality of care and making sure that the care is so good that people want to come back even if it's far away hospital?
So, ask it again.
Like, I know you like talking about earlier, think about like, you guys always like want like a lot of people to come to your hospital and stuff like that.
Right.
So like, wouldn't the easy like, I guess solution be like,
How do we get people to come to us instead of to a competitor?
Yeah, exactly.
Yeah. So remembering that that's important for us now,
Yeah.
but it ought not to be the driver for us later when the reimbursement changes to a population-based or a value-based reimbursement system. Okay, but today, it's the way you're describing it. So what do? We spend about $3.5 million a year in marketing, trying to tell people about the services we have and why they should take advantage of them. We employ, we have about 1,030 physicians on our medical staff. about 70 of them are employed. Creating that alignment between the hospital and physicians often results in increased referral activity from those physicians to the hospital. This is unfortunate in my mind, but people still don't make healthcare decisions based on objective data for a couple of reasons, not the least of which is it's so hard to get, and even if you get it, it's hard to understand. But the fact is, about a little bit less than 50% of people decide on where to go to get their care based on how far it is from their house. People will, 20% of people who are making a decision are basing it on a recommendation of a friend or family member. So we're already up to 60. And then the balance is a whole host of things. I think 10 or 15% was based on a recommendation of their physician. Remind me to talk about the recommendation of your physician, so I have a bit of advice for you. But anyway, nowhere in that, in the numbers I gave you, had anything to do with objective measures of clinical outcomes, right? So I know, for example, if you needed a hip replaced, I can tell you how many hips the doctor has replaced. I can tell you the infection rate. I can tell you what we call unplanned return to surgery, which means something went wrong and they have to go back and it has to be fixed. Blood use rates, how long what the length of stay in the hospital was. We know all of that. Nobody uses that information to figure out where they should get their hip replaced. You know more about a washing machine if you're going to buy it, if you look at Consumer Reports, then you're going to know about the people, the organization, and the person who's going to go fool around with your brain. It's craziness. There needs to be a shift to making more informed consumer decisions than there is now. Part of it's the fault of the hospitals because our organizations and our systems keep arguing, and the medical professionals keep arguing that the data is incomplete and insufficient for making a decision. And I'm telling you, it's a hell of a lot better than asking the neighbor across the fence or just going there because it's closer than someplace else. There needs to be a terrific thing that the government could do is require every hospital to publish all of this clinical information. So people who are, can access it easily, whether it's through an app or on the internet or through something that can be published in the newspapers or even provided on TV. And that's going to change, that's really going to change the healthcare world because it's going to drive meaningful improvement in the way care is being delivered instead of billboards that make all kinds of crazy claims not based on data. And by the way, when you drive down the highway, you'll see our billboard. Unfortunately, we don't make crazy claims, but we're spending money to convince you to go and use our services, but we're not doing it based on the clinical data. And the reason we don't do it is because no one else does it, and now you can't compare, right? So if I told you that 10% of the people, I'm making this number up, I don't know what it is, it's a high number, 2% of the people in our hospital who have a joint replacement get an infection. You have no idea whether that's a good number or a bad number. Should it be 0.005? Is the average 15%? So until everybody gets involved in this, it's a very difficult position to be in where you're talking to people about numbers they can't compare. Hang on one second. Did you have a question?
Yeah, so what you're proposing is kind of like a Yelp, but for doctors.
Yeah, doctors, absolutely. Yeah, I want to go to a website, I want to look at hip replacement, you know, and then I want to read batting averages. I want to know who's done a lot of them. I want to know what their outcomes are like. And don't forget, everybody you ask for a recommendation is alive. So you don't get to talk to the people who died. You don't get to talk to people who had really bad outcomes. The information you're using is just awful. And you know, here I am, the CEO of the hospital, but when if I have a health problem or friends or family have a health problem, I don't ever say, oh, just come to us, we'll take care of it. You You know, it's, what's your problem? And then get at the data to see where you'll get the best care. You know, sometimes if it's an emergency, you go to the closest hospital because that's just smart. But when you have time to shop, you need to shop. And I'll get to your question in a second, but I don't want to miss this point for running out of time. The biggest driver in the changes we're seeing in how we're delivering care is the fact that insurance companies, urged by employers who are paying the bill, are increasing the copay and deductible when you go to the hospital, you go to the doctor or the hospital. So what would have been a $5 copay when you go to the doctor might now be $50. And the coinsurance for the year, what would have cost you maybe $1,000, $500 if you're an employee in a company that provides insurance, it may cost you $7,000. So what the data makes clear to us is when it's $5, you really don't care how much it costs, right? Because it's only $5 to you. If the insurance company is paying $1,000 or $7,000 for the service, those people don't care, but they care about the $5, and that's not a lot of money, so they don't care a lot. But now that it's $50, people think twice, and with the deductible of maybe $6,000, $7,000, $8,000 a year, people care a lot. And for the first time that I can recall, well, I'll describe it to you differently. We never used to get calls from patients asking us how much something costs, because they didn't care. They paid their $50, $5, $100, $1,000, whatever it was, and then they could get hundreds of thousands of dollars in care. We get 300 calls a month from people who want to know how much things cost. And it's an interesting conversation. We can talk about it another time, but the narrow point is only, now they're acting like consumers. You know, and it's being driven by finances. It's going to result in the availability of meaningful clinical outcome information that they're going to start using, and they'll become, over time, informed consumers, because right now, they're really not. There's no transparency. You have no access, you don't have easy access to financial information, you don't have easy access to clinical information, you only have easy access to billboards. So it's just got to change. And you're dealing with people and organizations that have distorted incentives, right? I mean, we should try to keep you healthy, not take care of you, not simply take care of you when you're sick. I'll give you one quick, what time have we done?
No, we're good. The class actually goes till 2:40, so you have.
You just tell me when to stop, because I'll
Keep going, and I'll ask you a bunch of questions if they don't.
Okay, I'm going to give you one more quick story to put some of this in context. So I get a call from, I read every patient letter that comes in, I read all the patient satisfaction data, I read all the quality outcome data that we produce. And anytime somebody calls with a complaint, preferably a compliment, I take that too. So I get a call from a guy who wants to talk to me about his experience in our emergency department. And so I take the call, and I know it can't be terrible because he was the patient and he's still alive, so not terrible. It can't be that awful. So he starts off by telling me what a great experience he had in the emergency department. I came in and I was greeted by a friendly person. I was brought to an exam room quickly. I was seen by a nurse in the exam room and by a physician within minutes. People couldn't have been more responsive and concerned and timely, and they couldn't have kept me better informed about my care. And so I'm having the time of my life, because usually people don't spend a lot of time telling me about good stuff. And just on and on and on. And from the time I came in to the time I left, it was like a half hour, which is crazy fast. So I go, I couldn't be happier with this story. And he goes, well, and then I got the bill. and it was $1,800. So I'm thinking, that's nothing. I couldn't believe anybody would call to complain about an $1,800 bill, because we could charge much more than that. And he said it. So I said, well, so what was wrong with, why were you here? Well, I was getting ready for work, and I was cleaning my ear with a Q-tip, and the cotton ball came off. And I went to pull it out, and instead I just kept pushing it in. And my wife tried to noodle around in there, but that creeped me out. So I went to the emergency room, and you took it out. And I go, oh my God, $1,800 to take it out, a cotton ball out of your ear. He goes, yeah, that's what I wanted to talk to you about. So we had a really great conversation. Because I had to explain to him how something which on the surface is just unbelievably ridiculous, right? I mean, it was 20 minutes, a half hour tops, $1,800. And the answer goes like this. So in the year before we saw this fellow, we provided about $21 million in free care. Maybe a year before we saw him, we spent $522.7 million building a new hospital. That was $765 a square foot. If you were to build an office building down across from the campus, it would cost you maybe $150 a square foot to build. So when we build it, not only is a lot of the space obviously very expensive because of its complexity, it's also very safe. You never heard of a hospital burning down. There are all kinds of systems. We have 100% fresh air in the building so that it's not recycled like in this classroom, which is probably 60% recycled air, or like the airplane that you're flying. It's just immeasurable differences in the cost of construction. We're always open. So when there's a blizzard and you can't get to any store, you can't get to any doctor's office, you can get to just about any hospital. Any time of day or night, any weather conditions. We have a policy, just one miserable winter, we have a policy with staff that you can't go home until your replacement comes. Think about that. We have people who stay in the hospital for 3 days until somebody can finally, their replacement can finally dig out. We're paying overtime for all of that, as it should be. You know, it's not a complaint, it's just the cost issue. When you show up in the emergency room at 3 o'clock in the morning, we're ready to do just about anything short of doing a head transplant. All the people who need to be there to take care of whatever problem you have are available. Most of the time, they're not doing anything at 3 o'clock in the morning, but they're there. And as is our own fire department, security department, and a whole other set of craziness. I'll give you one number, and then I'll get off the example because I think you get it. Last year, we spent, not spent, I don't know how much we spent. We had to put salt down on the campus because of all the roads we have, and the miserable winter last year as well. We put down, I just heard this the other day, 600 tons of salt. I don't even know what that looks like. I can't even imagine where it comes from or how you pay for it. 600 tons of salt. So I'm talking to a guy about his Q-tip, and I'm trying to explain the craziness in what's going on in our organization. And then we divide that up between everybody. And a lot of what we do, it's a Robin Hood kind of thing. We take from the rich and give to the poor. Some insurances are better than others. Some people don't have the resources. We just take care of everybody the same way, regardless of their ability to pay, regardless of the contracts that they have. And by the time you're done doing this Robin Hood thing, some nice guy pays $1,800 for the Q-tip. The problem for us is going to be, he really needs to go to an urgent center, right? So he'll go eventually to like Walgreens or CVS. They'll charge him $40 or $20 or whatever it is. And that's absolutely appropriate. where am I gonna get my $1,800 to pay for those things that I just mentioned? So those profitable services will leave as is appropriate, and then we have to figure out how to make up for the loss of those profitable activities. And the way we'll do it is increasing our scale to improve our efficiency, having care managers who manage the care of patients through the continuum so they get the right care at the right place at the right time at the right cost. We'll have information technology that will allow us to consider best practices when we deliver care and make sure that people get what they need and that there's no twisted incentives in the system to provide care to people that's unnecessary or potentially dangerous. And that can make a big difference. Paying more attention to things that no one ever in our field ever paid attention to, like materials management. And how do you buy stuff? How do you move stuff through the system? How do you buy it for as little as possible? How do you waste as little as possible? We installed a environmental, we built a power plant that uses natural gas to produce steam, chilled water, and electricity. It reduced our energy cost, which was about $7 million a year, by about 25%. That's the kind of things that are that we need to be focusing on, as well as the clinical care and the people who provide the care. And the last piece of the solution, the big piece of the solution, is making sure that people who are providing care are working what we say to the maximum extent allowed by their license. So here's a simple example of that. You may be familiar with advanced practice nurses, which are usually bachelor's prepared RNs who go on for a master's degree in clinical nursing. They're terrifically talented, well-educated, skillful people. There have been studies done that say that they can do about 80% of what a primary care physician can do. There's a huge difference in how much time they spend in their education, the debts they have, and the income they receive. It becomes a less costly and terrific solution, clinically and financially, and others in the system. So everybody needs to be able to do all that they can clinically so that we're using people more cost effectively. You don't need someone with 20 years of training to do something that someone with 12 years of training can do. So we try to pay a lot more attention to that. You had some questions.
I do. I can ask a lot of questions, but I don't, yeah, go, Joe.
I have one more question. You said you built a hospital 2 years ago for $560 million?
Yeah, you want one?
I was just curious as to
Make an offer.
where the funds came from. Like how did you fund that such large endeavor?
Yeah, a couple of ways. We had about $60 million in savings that we were comfortable in putting toward the project, leaving enough cash behind to pay the bills and take care of anything threatening that we can imagine. So it took about $60 million in cash. We were planning the building for about 5 years, and each of those 5 years we had excess revenue of about $5 million that we put into the pile to pay for the project. We had the old hospital in Princeton. We had Merwick, which was our skilled nursing facility, which was on about 13 acres in Princeton. We had a surface parking lot. We had medical office buildings. We sold it all. And we raised about $90 million through the sale of real estate. Then we had a capital campaign. So through philanthropy, we were able to raise $172 million, which was really spectacular and allowed us to do things that we probably not probably, that we wouldn't have been able to do before. So we had savings, we had operating income, we had philanthropic support, and then we borrowed, and this is sort of the punchline maybe to the whole story, but then we borrowed $355 million from 4 banks. And and I don't know what that adds up to, but it's a lot more than the $522 million. And the reason we had to borrow that is we weren't certain that we would raise the $172 million. We didn't know when we would be able to sell all this different real estate and when we would get the money, or if we'd be able to, sort of expected, but we didn't really know how much we'd get for it. We just had an estimate for that. And we didn't really know how much excess revenue we would have in each of those 5 years. So there was a lot of winging and praying and hoping that things were going to work out. And we knew that we were not going to start the project unless we had enough money to finish it. So we borrowed that money, and son of a gun, they want us to give it back. So that creates that pressure on us in terms of our daily financial performance, because they want their money back, and they pay very close attention to how we do on a monthly basis financially. Yes?
What makes your hospital different than the 70 or so hospitals that did since you got big to open another one?
That's a good question during Passover. You know, why is this night different from all other nights like that? I think there are a couple of answers. I think I like to tell the board it's because of gifted leadership, but it's really not the answer. Part of it is location. You know, having a hospital in central Jersey, particularly in the Princeton region, the amount of free care that we have to provide is significantly less than it is for a lot of other hospitals. So if you're operating a hospital in any of the major cities in New Jersey, you know, whether it's Camden, Trenton, Newark, Patterson, there's a huge free care obligation that those hospitals have that creates a tremendous burden on them. Everyone hopefully does whatever the patients need, but that's very costly. We don't have that, even though we do whatever is necessary. Just by the fact of where we are geographically, it's not, that has not hurt us. That's probably the single biggest thing. Because of the quality of the services we have and our clinical outcomes and the quality of our medical staff, we've been able to keep pretty busy. And we are now often at capacity. And again, old world reimbursement system, that works. So we've been fortunate in being able to generate the referrals that we need to produce the bottom line. And there are a lot of people who work hard at that. We have the highest patient satisfaction scores in New Jersey. And depending on the quarter, we have the highest patient satisfaction scores in the United States. It varies because it's comparing it to a lot of other hospitals, and sometimes some guys do better, of course, but we're always in the top 5 or 10% in the country. And then when you look at things like infection rates, fall rates, error rates, we usually rank in the top 2 or 3 hospitals in the state. So we've been able to deliver pretty good care, results in people coming to us, and then we bill them as much as we possibly can. But the number one thing is geography and where we are in terms of what we call the payer mix. How many people are on Medicare, Medicaid, commercial insurance, or can't pay at all.
You mentioned all those statistics.
Yeah,
and stuff like
I
that.
made most of them up, but you believe me.
But I mean, I know you had said that no hospitals really advertise their specific statistics
Very
because
good, right.
No one's actually going to pay attention to it. But I mean, anyone who's taken the statistics course knows that people can skew the statistics to whatever benefits them. So I was wondering is there anything to prevent hospitals from doing that? I mean, you mentioned infection rates, but you could look at a specific side that helps you.
it's a great point. It's part of the answer goes back to why I think that it has to be required by a government, whether it's a state or federal, is another conversation. But it has to be required by government, and each of those numbers has to have very precise definition and methodology for calculating it. Otherwise, what you just said will undoubtedly happen. And it's not necessarily mischief, it's just there are a lot of legitimate ways of doing these calculations. So it has to be standardized. And it isn't. So even when I talk to friends who are doing similar work around the country, and I'm trying to understand how we're doing and relative to them. Here are two friends sitting there, and it takes us half a day to figure out whether we're measuring things the same way. So again, it's not necessarily a function of manipulation or mischief, just a lot of ways of defining, so there has to be a standardization behind it. And there is some. The Department of Health has some definitions, the Joint Commission has definitions, the Department of Health for the state of New Jersey has them. So they exist. It's just so hard to get, even when it exists, it's just so hard to get at, it's so hard to understand that it really doesn't have to be. The challenge in accessing it, I think, has been created for self-serving political reasons, not because people aren't smart enough to figure out how to make it. Travelocity is pretty easy to use, Yes?
So if Medicare, Medicaid, and insurance companies and them are paying hospitals based on the value system, like on the outcome, right? You said, what if in 10 years, half of those 72 hospitals in New Jersey are shut down? And then now it takes somebody longer to get to your ER,
Right.
and then they die.
Right.
But not because of your fault, it's just because it took them too long because the hospital in the middle was shut down.
Right.
Now that's put on you,
Yep.
right?
Well, let's skip the who it's on, right? These are all things that are being all primarily economically driven changes, but
Yeah.
it's an important question. So I think it works like this. On the one hand, if you simply rely on free market competitive pressures to rationalize the system, I think in healthcare you're going to run into problems because nobody's really incented to build a new hospital in Patterson or Newark or Trenton, and there are a lot of people who live there who need the care. So the economics of it aren't enough to do it. There needs to be some rational health planning. How you balance the two is an interesting thing to think about. But if we simply leave it to market pressures, I think whether it results in death or greater illness because of access problems, I think that would happen. So it requires thinking, and New York State has done that. They were faced with a situation where a number of hospitals started to close, and hospitals started to merge, and those merged hospitals started to close hospitals that were in their system. And the state said, well, wait a minute. You're making these decisions based solely on financial needs, and you're not considering the needs of these different populations. So we need to work together and come up with a more rational solution. So they did. One of the things these changes need to be managed, not just happen sort of as serendipitously as they may be happening now and in the next couple of years. But the other thing is, we don't need 73 hospitals. 2 points. We use the word hospital as shorthand, I think, in most people's minds as beds and inpatient stuff. Well, half of what most hospitals do is outpatient anyway. So the first question is, how many beds do you need? How much outpatient resource do you need? Where should those resources be? How much should be done in an emergency department versus at an urgent center? What's appropriate for the urgent center? How much could be done in a physician's office? And all that has to be rationalized. And a lot of good work is happening driven by those financial pressures. Other than that part where the government needs, I think, to be involved to make sure that underserved populations continue to get the care they need, I think the economic pressures will rationalize it. I think we're gonna have more dispersed care. So you need to get to an emergency room, depending on your problem, pretty quickly. You don't have to get to the hospital to have your knee replaced or your ACL mended within 20 minutes, you know? So if it takes you an hour or two, which would hardly happen in New Jersey because we're not even that big. But you look at other states, or even Western Pennsylvania, Western Massachusetts, there's a lot of space between the hospitals, and they don't have, and people in the country aren't dying on their way to the hospital because the care wasn't available. There are exceptions to that. But those are extreme situations where you've got hundreds and hundreds of miles between providers. There aren't hundreds of miles between anything in New Jersey, you know, so it's just important to keep in mind, we say hospitals, it sort of means, in a lot of people's minds, beds, and that means inpatient, and there'll be a lot less need for inpatient care. I'll give you a quick example of why. So we just bought 2 new robots for doing robotic surgery. It used to be where the procedure that was being done would result in a 3-day stay. You know, it was done traditionally, open and complicated. Now it's done robotically, and for a lot of the patients, they can go home the same day. It's terrific. There were certain brain surgeries that would result in 7, 8, 12-day stays. It's now done with radiation, and you can go home the same day. So pharmaceuticals, technology, changes in how care is being delivered are all naturally, forget about the economic drivers, they're just naturally resulting in reduced lengths of stay and fewer beds. But most care is going to be, this is a great example. General Electric has produced, they're testing it now, a sensor which is to be injected into your bloodstream that will pick up the protein that's produced by the heart during a heart attack. And it picks up these proteins at very, very low levels before you would be aware that there was a problem. In fact, the preliminary research says that it picks it up maybe 3 hours before you know it. And it calls you on your cell phone. So I'm so superficial, all I can think about is, what's the ringtone? You know, what is it, when the sensor calls you, what sound is it making on your phone? So you have to think about that for a while. But, you know, there's this extraordinary technology, that's the most wacky one I've heard of. But there's all this technology that's being developed for use in the home, and or technology that could be used in a doctor's office that would have cost gazillion dollars in the hospital. So the technology is enabling us to really shift the location of care to much more, to much earlier detection and to much lower cost environments. And that's going to be also a huge driver in reducing the cost of care. Yes?
2 years ago, the hospital that's down the street from my hometown, it closed down, but they were able to keep the emergency room open. But where's the money? Do you have any idea where the money's coming from to keep the emergency open?
Which hospital is it?
Muhlenberg?
No, and you know, I thought about a situation like that a couple of years ago, because when the hospital was in Princeton, some of the folks said, keep an emergency room here and move the hospital to wherever you want to. So I didn't like the idea, but I tried to think through the ramifications of it. So I don't know the answer specifically to Muhlenberg, but I don't know how that works, because when I look at our emergency room, if I show up tonight with the worst headache I ever had in my life, and I think I might be having a stroke, you've got neurologists, neurosurgeons, you've got all these specialists who are right there available to take care of me, or if a kid shows up. You know, we've got pediatric emergentologists who are available.
we have, and we're not unique, I mean, you know, a more comprehensive situation than what you're just describing, more like our hospital. We've got all this incredibly expensive technology, whether it's linear accelerators or MRIs, as two good examples, that are just sitting there waiting for you. I don't understand